Thank you, Ed, and thank you all for staying till the end. It's always hard being the last speakers of the day. So I'm going to talk about this topic, which I think is probably an issue for all of you. We're seeing more cases of C. diff in our IBD patients, and just go through where we are in terms of latest diagnostic tests and also therapies. So I can't move this slide. Okay, there's my disclosures. So I'm just going to reference it around a case to give you some framework for this. So it's a patient you see in the office, a long history of UC, was doing great on mesalamine, but unfortunately gets antibiotics for an episode, in this case diverticulitis, and then their colitis flares up. And so despite upping their dose of mesalamine, they continue to flare. You test them for C. diff. Initially it's negative. They end up on prednisone. You test them again. Their test comes back positive for C. diff. So they're now on prednisone, mesalamine, and a positive C. diff test. So you put them on first-line therapy, which would be metronidazole. And 5 days later, they're still having ongoing symptoms. You do a SIG. They've got some active disease. It's not classical pseudomembranous colitis, but their disease is still active. They've had a partial response to metronidazole. They're on prednisone. And the question really is, where do we go next with this patient? Is it primarily the active colitis is driving their symptoms? Is it primarily the C. diff infection, or really what's going on? And I think so there are really 4 questions, and I'm going to address 3 with them in the next 10 minutes, and I'll leave Ed to address the last question. The first thing is we're increasingly using PCR testing for C. diff. So what does that mean? What are the clinical implications of a positive PCR test in these patients? The second one is, does it matter which antibiotic I use to treat my IBD patients who develop C. diff? And then finally, a lot of these patients are on escalating doses of immunosuppressants. Do I need to stop those because of the C. diff infection? Does it matter, the immunosuppression, in terms of their response to C. diff therapy? So the first thing is to look about testing. The challenge with diagnosing C. diff in our patients, as you all know, is that they essentially look the same. Both conditions, patients have pain, diarrhea, and they have abnormalities on their endoscopy tests. They have elevated biomarkers, for example, calprotectin. And yet it's very hard to distinguish one from the other. If you look at patients with IBD, about 7% with active disease are diagnosed with active C. diff infection. Other studies have shown higher rates, but in the last year there have been 2 big cohort studies showing about similar results. About 5 to 10% of patients with active IBD have concurrent C. diff infection. One of the interesting things in terms of diagnosis is the introduction of PCR testing. Now, I assume for many of you, like in our lab, PCR testing is now the only test available to test for C. diff. The advantage of this is that it's an extremely sensitive test. You're picking up to 10 picograms of genomic DNA with most of the commercially available PCR tests. That's great. The problem is, are all those patients infected, or are they colonized, or what's the consequences of a positive PCR test for C. diff infection? Most of these commercial tests are measuring conserved regions of the toxin A or toxin B gene. And if you look at the positive predictive value, the PPV, versus a standard of care historically, which would be a toxigenic culture, it varies from 40 to almost 100% in different studies. But the clinical specificity, so what are the clinical meaning of a positive test, is often unclear. Are these patients truly infected, or are they just colonized? In many centers, when you switch from doing ELISA-based toxin testing for toxin to purely PCR testing, most centers report a doubling of the prevalence of C. diff in their population, reflecting a much more sensitive test. There have been one very big study within the last year, 2,500 inpatients with IBD looked at this. They looked at testing with EIA versus testing with PCR, and they found in the IBD patients they had similar prevalence of positive tests, 4 and 5% with both tests, whereas in their non-IBD patients they almost had a doubling of positive tests for C. diff when they moved to PCR testing. So I think the message from this slide is a positive PCR test may well mean infection, but in some patients it may well mean colonization. And just to keep that in mind when you're thinking about altering therapies in our IBD patients. A nice example is a study just last year from Children's Hospital where they took archival samples of patients with IBD and they did on the same samples ELISA testing for toxin and PCR testing. I think the interesting thing here was of all the PCR positive tests for C. diff, only 10% would have been positive by the original ELISA test for the toxin. And so their conclusion, I think a conclusion you may well raise from this also, is that if you're PCR positive, toxin negative, some of these patients are just colonized and not actually actively infected by C. diff, although the ID people may say, the distinction is unclear, particularly in our IBD patients where, because this is in the setting of having ongoing diarrhea if you don't have IBD, but all these patients with IBD have diarrhea when they're active. So that's where we are with testing. I think PCR has replaced most centers as the test of choice. You've got to be cautious about interpreting a positive PCR result. And maybe, if you're not sure, consider doing toxin testing in that setting if it's still available to you. The other area that's interesting is in our patients who are C. diff toxin positive or PCR positive, which antibiotic to use to treat them. Now, as you know, all the clinical trials in treating C. diff with different antibiotics have excluded the IBD patients. So we're really left with our retrospective studies or cohort studies from IBD centers and what they've done in practice. This is the biggest study I could find. This is from Gil Melmed's group in Cedars, and they took 114 patients hospitalized with IBD. 20 of those were UC patients with severe C. diff infection. And they looked then at, as you can see here, they looked at their readmission rates in short and long term, their colectomy rates, and their death rates between those patients who got metronidazole and those patients who got vancomycin. The caveat here is that most of the patients who got vancomycin got it after transitioning from metronidazole or got it both together, so they're not pure just vancomycin and just metronidazole cohorts. But they found pretty remarkable difference. The patients who got metronidazole, most of them, 70%, required readmission within that 12-week or 30-day period, versus none of the patients who got vancomycin were readmitted. There were small but non-significant differences in colectomy rates and death between the two groups. The other caveat here, of course, is this is not control for disease severity. So it may have been that the antibiotic of choice is not the reason for the readmission, it was how severe the disease was in the cohorts. But it certainly is some useful data in guiding in patients with more severe disease who are hospitalized with IBD, the potential differences between the two antibiotics of choice for this setting. And so a kind of an algorithm that a number of groups have recommended is that for patients with non-severe disease in the outpatient setting, metronidazole is just fine. For the patients with more severe disease, and that's either more severe IBD or more severe C. diff infection, they should be treated with vancomycin as their first-line therapy. The so-called complicated patients, the patients in the ICU, are recommended to give them at higher doses. And then the patients who have recurrent relapses after their initial course, first-line therapy, as in the non-IBD population, would be the vancomycin with taper. There's some very impressive data on fecal transplantation in this setting, which Ed will talk about. And then rifaximin and fidaxomicin are alternatives if that's not available. And so I think that's an algorithm to think about with our patients, dividing those with severe disease versus those with non-severe disease and choosing your antibiotic accordingly. You may ask me, well, what exactly is severe IBD in this setting and what's severe C. diff infection in this setting? And as you can see from this slide, there's quite a lot of overlap between what you might use to categorize severe IBD and what you might use to categorize severe C. diff infection. You can see albumin appears to be important, hemoglobin. If you look at this patients, this is from, I think, Ashwin's group, patients with severe IBD and C. diff infection. The patients who had these characteristics on the left had a almost 5 to 9-fold greater risk of colectomy than patients who didn't. So they'd be markers for a bad outcome in patients who have IBD and a C. diff infection. And in general, patients with C. diff infections in general, the columns on the right show all the markers of a severe C. diff infection, regardless of what underlying disease may or may not be there. And often we'll scope these patients in the inpatient setting, do a SIG, as Russ had mentioned, to see what's going on. If looking for pseudomembranes, does that help? And the answer is no. If you look at studies that have looked at the endoscopic appearance in patients with IBD and concomitant C. diff infection, most don't have pseudomembranes. Most look like the typical moderate to severe UC flare from an endoscopic appearance. So taking a quick look in and looking for pseudomembranes is not really going to be helpful in the vast majority of cases. And so the final question then is, you've got your patient, they're on your antibiotic of choice, you've confirmed the diagnosis. What do we do with immunosuppression? They may be on high doses of infliximab, they might be dosed on high doses of prednisone. What are you going to do with those in your practice? And does it matter, I guess, is a more important question. So if you ask the experts at often these meetings, it's 50-50. Half the experts think you should stop the immunosuppressant, half the experts say you should continue the immunosuppressant, so that's really no help. There was a nice study from the ECHO, the European Crohn's and Colitis Organization, retrospective looking at 150 patients who were hospitalized with IBD and C. diff infection. Most of them were treated with metronidazole, and they looked then for what factors predicted a bad outcome for those having C. diff with IBD. And what they found was the risk factors for either death or a colectomy or megacolon or shock, all the worst things that could happen. If you were on more than 2 immunosuppressants, that put you at a higher risk of these outcomes. And also if you had a low albumin, which is a risk factor for having severe disease of C. diff infection anyway, that also put you at higher risk for those outcomes. And so, you know, you could argue, well, was 1 immunosuppressant better than 2? In this study, that was not as severe or not as high as predicting your risk of these severe outcomes if you were on just on 1 immunosuppression. So one approach might be, well, you might just keep them on their 1, but if they're on combination therapy with 2 immunosuppressants, you may consider at least removing 1 for that interval because of this higher risk of this more severe outcome. I think in practice, and we may see at the end what the people's thoughts are, I generally keep them what they're on because most of these patients are having a flare, and if you don't treat their IBD, you can treat the C. diff till the cows come home, they're not going to get better. And so to give you an example in this patient, so he was partially responding to metronidazole. We put him on vancomycin. He had all the markers suggesting more severe disease. He had low albumin. He was older. He had a high CRP. And on vancomycin, he was still in that 4 to 6 stool a day range. So he's better, but he's not in remission. And so then we gave him an infliximab infusion. And within a week of that, and similar to what we discussed with the severe UC patients, he started to have an improvement. And so probably we'd addressed the C. diff, but addressing the C. diff alone wasn't enough to address his severe colitis, and he eventually needed more potent immunosuppression to drive that down. His CRP came down, he discharged on vancomycin taper, and then was able to taper off that, remain on maintenance infliximab therapy, and keep him in remission. Thanks for your time.